Hello everyone and happy Friday. Can't think of a better way to start the weekend than talking about OSCEs. Yay! That means our semester is almost over, so that's the good news. The bad news is we need to get through the OSCE first. So I'm going to give you a high-level overview of what that day is going to look like, at least in regard to the OSCE portion of your on-campus event. So, with this video, I will post a few other resources for you. I'm going to post a detailed checkoff schedule, which will indicate what faculty member and what time you will be checking off and performing your OSCE. I will post a grading rubric that will apply to all of the different OSCE scenarios for your reference. I will provide you a list of possible diagnoses that you'll encounter in your OSCE. And I will also post a preceptor presentation guide, which is at the conclusion of your OSCE. It's your bullet presentation, and I'll go over that with you. So the way that the day looks is you will need to dress professionally. You will need to wear your lab coat and bring your stethoscope. Really the goal of this is that you're approaching this like any other clinic day. We are using standardized patients, so those are paid actors that will portray the role of your patient, and they have been given their assigned diagnosis or script ahead of time, so it should be a fairly natural interaction aside from the faculty member sitting in there watching you, of course. So when you enter the lab for checkoff, you will be provided a sheet of paper that gives you the case background. And within the case background, it will tell you the name of your patient, the age and the gender of your patient, and it will give you just a little bit of background info on the patient. Basically, this case background paper is mimicking what your nurse would be giving you, essentially, after they've roomed your patient. So they'll tell you the name, the age, the gender, a little bit about why they're there, and then it'll give you a little background information as far as the community setting of your clinic, but then it'll also give you very specific information about the clinic. So whether this is a rural health clinic and you're the only nurse practitioner, or if this is a practice that has multiple providers and has on-site radiology, basically you're going to get all of that information so that you can also get into the role and basically know where your setting is for your patient encounter. So you will then, once you're done reading this, you're just given a couple of minutes to look this sheet over. You will knock on the door, and the patient will indicate that you can come in. You will introduce yourself, shake their hand. You'll want to sanitize your hands, and then you'll begin the visit just like you would any other patient encounter. So after you introduce yourself, you'll want to start with the chief complaint, and you'll want to elicit that by asking an open-ended question. So tell me what brings you in today, or what can I help you with today? I don't care what words you use in particular, just make it polite, professional, and open-ended. So after you have obtained the chief complaint, then you're going to start getting your HPI information. The HPI accounts for 7 points, and those 7 points are derived from the information that you would get like using an old carts format, for instance. So I always suggest that when you are writing notes, you're allowed to take in a piece of paper and a clipboard and write notes. that just go ahead and write out your old carts so that you don't forget to ask any of those things. So the onset, location, duration, character, radiation, aggravating and alleviating factors, timing, severity, and if there's any associated symptoms. So you'll want to make sure that you go through each of those points, no matter what the complaint is. Just go through all those points, okay? That's 7 easy points right there. All right, and unlike a typical patient visit, this varies a little bit in that you have to elicit your own information, meaning you need to review the patient's medical history. You need to ask their family history, what their surgical history is. You need to know what meds they're on, their allergies, and then you're going to want to ask them their social history as well, specifically tobacco use, alcohol use, illicit drug use, what their occupation is. So that's a little bit different from a routine visit. So maybe in your mind assume that this is a new patient. You just don't know that information on them. So, get your HPI, and then I would go for all of that information there just to make sure you can check that off, because that's worth 4 points. And then you need to complete a review of systems. The review of systems is going to be worth 4 points. So keeping in mind that these are problem-focused visits, we don't need a full review of systems. I need you to ask things that are relevant. Only focus on the relevant systems to the chief complaint. So if you, for instance, your patient is there for shoulder pain, you may or may not need to ask them about their urination. I mean, maybe you do, but probably not. So just, be cognizant of relating your review of systems to your chief complaint to the best of your ability. That's a critical thinking there. So, all right. So chief complaint, the HPI, you have to go through the medical, surgical, family, social history, meds, allergies, go through your review of systems, and then you'll complete a physical exam. This is a good chunk of your points. It's worth 16 points. And you only need to examine items that are relevant to, your chief complaint. Obviously, if your shoulder hurts, probably don't need a monofilament exam, okay? So you don't necessarily get a point for just examining a random part. It needs to make sense to your chief complaint. And when you're doing your physical exam, much like you did an advanced health assessment with your video recordings, I need you to verbalize what you're doing. Just think out loud, essentially, okay? And that way there will be no question for the faculty that's grading you as to what you're doing, what you're looking for. For example, if you're looking at an ear, you'll say, I'm going to use the otoscope to visualize the tympanic membrane. I'm going to stabilize the outer ear and look for a cone of light and my bony landmarks. If there are abnormal physical exam findings, your faculty member will let you know that, okay? So you don't have to guess what you're looking at necessarily, but we need to know that you are what you're looking for as far as normals and or abnormals and how you're going to do that and why you're doing that. So just thinking out loud, essentially. So once you have completed your physical exam, Then you're going to need to cover your diagnostics that you plan on ordering. And again, trying to make this as much like a real patient visit as you can. If you're seeing the patient, and you want to order, labs and some radiology, explain to them, well, Mr. Smith, I'm concerned about your symptoms, and I think we need to get both some blood work and an x-ray. As far as the blood work goes, I would like to order a complete blood count with differential, a comprehensive metabolic panel, and a thyroid function test. And those labs there will tell me, a little bit about if there any overwhelming infection, is there any anemia. It'll let me know how well hydrated you are, kind of a baseline essential organ function, electrolytes, and how well your thyroid is functioning right now. So that would be why I want to order those things. And then with the x-ray, I want to get a 2-view chest x-ray. And that's going to let me take kind of a baseline peek inside your chest. It'll let me look at how well expanded your lungs are, the size of your heart, and just making sure that there isn't anything unusual there. Make sure there's no pneumonia or other concerns within your lungs and your chest cavity. So that's how you would explain that. Okay, so you don't necessarily just turn to your faculty and say, I'm going to get a CBC and a chest x-ray, because you kind of need to pretend that your faculty isn't there necessarily. We're trying to see how you're interacting with your patient. So keep that in mind. Once you have discussed your diagnostics that you're going to order, that is when you're going to discuss your differential diagnoses with your patient. So, again, trying to make this as natural as possible, but still allowing your faculty to understand what it is that you're trying to communicate. You'll say, well, first and foremost, Mr. Smith, I'm really concerned that you have pneumonia, and that's my priority diagnosis that I'm looking for right now. In addition to pneumonia, there's a few other things that it could be. Maybe you have a really bad bronchitis, or maybe you have heart failure. The blood work and the x-ray that I ordered, that's going to help me figure out, if it is or is not those things. But moving forward, my diagnosis for you is pneumonia. So that is kind of how you're going to have to word that. Again, if it's not totally natural because you're nervous, we understand that. But really the point is you're identifying your priority diagnosis and you're identifying your differential diagnoses. I would expect that you identify 2 differential diagnoses related to your case. So your priority diagnosis, 2 differentials, okay? Once you have identified those, that is when you're going to start talking about your plan or the treatment that you are hoping to administer for your priority diagnosis. So you'll want to talk about whatever it is that you ordered lab-wise or radiology-wise. You'll be given those results there at the bedside. Your labs will indicate a normal reference range, so you don't have to memorize every lab value ever. But your radiology and or EKGs are not going to come with an interpretation. I'm not expecting that you're going to give a the same level of interpretation as a radiologist. But I would expect that if there's a big honkin' pneumonia on there, that you see that and confirm, oh yeah, look, this infiltrate here is exactly what I thought it would be. This confirms that you have pneumonia. I don't want you to stress about the interpretation of, like the radiology and EKGs too much, because truly, if you did what you should have done in your HPI and your review of systems and your physical exam, you already know what the diagnosis is, okay? Your studies, your diagnostic tools help confirm what you already know. So rarely are they going to change what your priority diagnosis is if you've done everything else correctly. So, again, don't stress too much about the interpretation aspect of that. It's going to be pretty simplistic, and that's not really the focus of this. But just know, if you're getting the correct information from your HPI and review of systems, your diagnostic tools just help confirm that. Okay? All right. So with your treatment, you're going to outline your treatment, your plan of care with the patient. You need to do this, kind of in conjunction with the patient, making considerations for being patient-centered in your approach to that. So you'll want to talk about medications. If you are prescribing medications, you'll want to talk about the dosing, ideally. You will get a point off if, you don't have the proper dosing. Again, I haven't quite worked out the weights on the grading of like how heavily that's going to be weighted, because you don't have access to your point of care resources during your OSCE. So I don't expect that you have every medication dosage memorized. I mean, that's not reasonable, and that's not the goal. We're not here to be unreasonable. But I would want you to have some kind of ballpark idea about how you're prescribing things that are common, okay? Let's see, what else in your plan? You'll want to talk about any referrals, should you be referring the patient anywhere. You're really going to want to go in depth with the patient education, back with your pharmacologic interventions. You're going to want to talk about expected side effects or any important details relating to the medication. And then you're going to want to talk about follow-up. Follow-up is really important, and you need to be definitive about your follow-up. Meaning you can't say, I don't know, come back in, 3 days to 6 weeks. That's a huge window there. So be more precise when you're telling someone to follow up. Okay? Again, that's not going to be weighted super heavily in that you are exact on, you will follow up in 6 weeks and 3 hours and 45 seconds. Meaning, I just want you to have a definitive idea that they will be following up in some kind of rational, reasonable time frame that makes sense. Okay? So, because everyone practices a little bit differently, someone might follow up their new hypertension patients in 2 weeks. Some might do 4 weeks. And I understand that. So, if you can say, I'm going to have you follow up in 2 weeks because of XYZ, or I'm going to have you follow up in 4 weeks because XYZ. Great. Okay? So you're not going to get points if you just say follow up anywhere between 3 days to 6 months, because that's just not how that works. All right. Again, the education component, explaining the pathophysiology to the patient, explaining how you arrived at the diagnosis, explaining what the expected outcome is going to be, and kind of what that looks like for them for the future, both immediate and long term. So, all right, once you have, excuse me, covered the plan aspect, that is when you're going to then give your preceptor presentation or your bullet presentation. And again, I'll give you an outline, but really that covers a whole brief overview of the visit. So, the demographics of your patient, their chief complaint, the HPI, making sure that you're highlighting those 7 important aspects. You're going to go over the review of systems, and again, just highlighting the pertinent positives and negatives. You're going to review your physical exam findings, focused exam findings, things that are relevant, pertinent positives and negatives. You're going to discuss your priority diagnosis, your differential diagnosis, what diagnostics you ordered, and what your treatment plan consisted of. That accounts for 16 points. So, again, that's another big chunk of this is, can you regurgitate all of that information and synthesize it into a reasonable format, hopefully like you're already doing in clinical, but you will actually be doing that in real life practice if you need to collaborate with someone. So it's a good habit to get into so that you can sound professional-ish. All right. That's pretty much it. Just hit those 255,000 points, and that's pretty much it. That's the whole OSCE there. You're done. No problems. What else do I need to tell you? Oh, yes. It's 74 points total. It is worth 20% of your grade. And you need to get at least a 70% on your OSCE to pass the course. So, don't let that scare you. If there are any issues with hitting that 70%, I will work with you individually to figure out what the next step will be. So, again, these are high stakes, but it should be. We're dealing with human lives, so of course, it's going to be stressful, but just know that this isn't set up to allow you to fail. Will it be challenging? Absolutely. But it's not a trick. It's not impossible. And I will work with you in whatever way that I can to help you get through this and prepare for this. So that being said, excuse me, I encourage you to obviously review this video. Think about any questions or concerns that you might have. I'm going to try to post a discussion board with this video so that if you have questions, I would encourage you to post them within the discussion board so that everybody can see them, so that I'm not answering the same question via email, 24 times. I think I'm going to also add just some open office Zoom hours that I'll post, meaning I'll just be logged into my Zoom room here, and you can hop on at any point in time during the days and times that I'm on here and ask questions. So not a recorded session, but just kind of an open, like if we were on campus and you walk down to my office and with a question, basically. And then I also hope to maybe review and discuss this a little bit and do a review prior to the comprehensive final exam. I know there isn't a scheduled review on the schedule for the comprehensive final, which is technically in NU 830, but all of you are enrolled in that class too, so they kind of go together. But I do think a review before the comprehensive final would be a good thing. And again, because I haven't pre-scheduled that, I will likely just record it and post it. Or I might post a date and do a live session and you can attend if you want, just knowing that I'm going to record it and post it for everybody to view, just because I know schedules are very, 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 very busy at this point in time. So, all right, I think that's all I have for you for right now. Hopefully that was helpful and not too confusing or frightening. Yeah, let me know what your questions are, okay? All right.